Well, hello. My name is Dr. Amin. Thank you to Dr. Walker for allowing me to do this presentation today, and thanks to the great team at NCVH for hooking me up with this with Tom, Lauren, and Jonathan, and the other team. So thank you. So we'll get started. So today's topic is turbo power laser with treating SFA. I'm a cardiologist here at Cardiovascular Institute of the South and an associate professor at LSU, and we'll get started. So disclosures-wise, the speaker bureau with Phillips in the IVUS area, and then PVD training for BARD. So laser, as we know, is a simple acronym known as light amplification by stimulated emission of radiation. So we use the actual excited state, and once that is removed, you get the 308 nanometer light, which is specifically used in reference to the laser atherectomy device. So lasers in this light spectrum, ultraviolet versus infrared, as you can tell, the excimer laser itself is more on the 308 nanometer, the cool side, where you can actually see CO2 infrared on the other side. So important tissue factors to remember is that absorption depth, absorption mechanism, and absorption losses in any kind of laser passing through any kind of tissue. And so absorption depth, different laser wavelengths absorb at different tissue respectively, and your absorption depth must be minimal. So the 308 nanometer light has a very low absorption depth into tissue itself. Therefore, does not destroy or disrupt any surrounding deep tissue. The mechanism itself, it's light energy, is either absorbed, transmitted, or reflected, refracted, or dispersed. The arterial plaque absorbs this specific 308 nanometer light, and therefore the thrombus itself works best for this atherectomy tool. Lipids and scar tissue absorb well, along with calcium, which is the most resistant to absorption. So the photochemical aspect, so UV light hits the pulses, hits the tissue at 125 nanoseconds in duration, and it's 100 microns of penetration, and there's billions of tissue bonds which are fractured per pulse. And so there's a photothermal side also, and this time scale is about 25 to 120 microseconds, and the ultraviolet light is absorbed and it produces a fast vibration of molecular bonds in the tissue, and this vibration heats the intracellular water. The intracellular water vaporizes, exploding the cell from the inside out. Macroscopically, the vaporization forms a steam bubble that expands approximately twice the diameter of the catheter tip. In the case of solid tissue, the vapor bubble forms back up at the catheter shaft. Process time is less than the thermal relaxation time of the tissue, and the heat does not diffuse into the tissue. The photomechanical aspect of this, this time scale is about 120 to 400 microseconds. So it's about 120 to 400 millionth of a second after the laser pulse. This is the fast expansion implosion of the steam bubble, produces cavitation and pressure effects that further break down tissue and assists in sweeping ablated debris from the face of the catheter. The debris itself, the byproduct, consists of water, hydrocarbons, which are gases, and small particles. And then notably absent are the oxidative byproducts, which implies that the molecules in the tissue do not burn. More than 91% of the particles are less than 10 microns in diameter, and this is the same size as a red blood cell. So ablation depth is approximately 10 microns per pulse. This is a very slow process, and so secondary cavitation bubbles can form after the implosion of the first vapor bubble, further assisting in tissue ablation and removal of debris. So the entire process itself per pulse is over approximately 500 millionth of a second, and the next pulse arrives 24 milliseconds thereafter. So the laser flow ablation, this clinical uses, of course, plaque and tissue vaporization on contact. Thrombectomy, as mentioned before, the 308 nanometer works extremely well in this kind of medium with the contact and the vapor bubble. Pacemaker lead removal also, crossing CTOs, either coronary or peripheral, which is a step-by-step fashion. Energy modulations, if you've been familiar with the laser device itself, concentrate in two areas, the frequency, which is calcium related, and then the fluence, which is thrombus related. So the higher the frequency, the more calcium fracking in a way you can do, or if the fluence is higher, the more thrombus resolution you can get. So what we've learned over time, ablation speed is the key, no faster than 100 millimeters per second. Never laser in contrast. That percussive wave can cause a serious dissection or even a perforation. Always use saline flush when using it. The effect of the eczema laser itself in thrombus is the bubble effect, as we mentioned before, can dissolve a remote thrombus. And then calcium lesions seem to respond to very high frequency. So this is a courtesy of Dr. Walker himself. This is just showing is a bedside or bentside testing, which he did. Laser and saline, as it shows you how the bubble itself you cannot see. However, in contrast, it's a vast difference, and we try to stay away from that, hence the complications known with it. Another one is the vapor bubble in a gel model. As you can tell, you can see the propagation of the actual vapor bubble itself, which is pretty impressive. And then finally, you can actually see the closed tube with the clot and saline on how actually the laser works in removing or resolving the clot burden. So moving on, that was just basic information on the laser itself. Now we're going to talk about treating de novo SFA disease with the turbo power itself. So back in the past, we did have the old turbo elite standard, was very eccentric, is indicated for Fem-pop ISR. It was clinically superior and in safety and efficacy with maximum luminal gain. Then came the newer iteration, which treats at the tip, easy use, and now as a combination of both to be the turbo power. Now it's indicated for the Fem-pop ISR, clinically superior, maximum luminal gain, and treats at the tip and ease of use, and which we'll talk about in just a minute. So this new standard for de novo SFA, like I said, it treats at the tip, eccentric vaporizing technology, remote automatic rotation, and precise directional control. The buttons over here actually control the orientation, which actually spins the device. It's easier to prepare and easier to operate than previously turbo tandem devices. So it's a quick overview. As I mentioned, the device is right there. It actually turns and rotates the rotation area, which is the distal third of the catheter. There's a flush port up here, the on and off button, and a little tab that you pull off the back to get it started. As you can see, the distal treats right at the tip. It's an eccentric fiber pack, which needs to be remembered. It does have a radiopaque marker, so you can see this. It comes in various sizes. There's a 6 French, which is, the 2.0, which is 6 French compatible. And then there's a 2.3 version, which is 7 French compatible. And like I said, all on a 125 shaft. Can be used for femoral up and over and pedal access cases. As mentioned, the fiber pack is tightly packed here in the eccentric lesion. The 0.018 wire does come up here. Has to be an uncoated wire. You can't ablate over the distal part of a wire which is coated. And so our goal is to gain maximum luminal gain. The success begins and ends with luminal gain. So the eccentric fiber bundle and precise directional control and provide up to 21% greater luminal gain when compared to the previous iterations of the Turbo Elite 2.0. So technique details. So the device rotation, maximum 6 rotations in each direction. So the button over here in the corner, you press one time, it rotates that way, and then full rotation back. The original tip and the distal 1/3 of the catheter rotate as mentioned, and then turning initiated from the torque wire at the motor of the base. Always will not always have that 1-to-1 torque response from the tip to base, and it just vary on anatomy. So here we go. So initial angiogram, as you can tell, nice CTO of the distal SFA at the costal level of the ductal canal. And there's the laser coming down. As you can tell, very slow, 1 millimeter per second, slow push towards down, towards the CTO part once the wire has been crossed. Here's an angiogram post-laser, and then the post-drug-coated or post-drug-eluting balloon. And as you can tell, an excellent result. Hopefully it's going to play, and there it goes. So laser for instant restenosis. So nitinol cells are being used a lot more common these days in the therapy of SFA popliteal and for popliteal disease. Reports have shown improved patency and better symptomatic relief. However, do we have to worry about this instant restenosis phenomenon? Stenting is crucial with flow-limiting dissection, which is a bailout therapy after prolonged balloon inflations don't work. So instant restenosis is common over time, and interventional therapy of ISR has historically been associated with high restenosis rates and complications. So restenosis is secondary to intimal growth and fully expanded stent, and reocclusion usually has superimposed thrombus, and which is a key factor of this. Stent fractures also have been noted. Historically, treatment of long diffuse diseases and occlusions showed very poor patency, and in one study had less than 20% at 3 months with high embolization rates. Histology-wise, a neointimal hyperplasia, as you can tell, the stents on the outside here. It makes up of 15% cellular material and 85% extracellular, and it's a very high water content. Morphology-wise, as we mentioned, the Fem-pop ISR is a unique stubborn disease. The first-time ISR is about 30 to 40% recurrent ISR from usual just angioplasty, 63%. The primary lesion, as mentioned, is hydrated collagen matrix, and which is high restenotic rate. And the key that we found out is using laser atherectomy along with adjunctive therapy, along with balloon angioplasty and potential DCB therapy to improve rates. Decrease rates of restenosis. So the repeat ISR is highly prevalent, and so it's an injury process that you start the vessel injury from treating initial ISR inflammation, then you get the neointimal hyperplasia, which we try to minimize as much, and then vessel injury from treating the hyperplasia and recurrent ISR, and it starts the vicious cycle, unfortunately. Factors for ISR lesions, as you mentioned, the mechanical intervention injures the vessel itself. This develops over time and is prevalent in muscular arteries of the periphery. As you can tell, vessel trauma, vessel stretching, removal of endothelium, the rupture of the layers itself, and then medial damage. And then the factors itself is just the impingement of the distal stent at the lever close to the adductor canal, the hinge point of the knee. And you get those longitudinal lengthening and shortening factors, torsion and twisting, and then the bending actually itself. And this stent motion occurs with every step and every flexion and extension, and the arteries naturally wants to shorten as part of the process itself. As you can tell here, the highly dense lesions can occur at the edge of the stent itself. And then as you can tell, once you do flex that leg and extend it out, you do see the stent pinched off just by this process itself. And this is where we get a lot of failure rates, especially. So we have to be very mindful of that. As mentioned before, just plain old angioplasty is not proven to be beneficial in the solution of ISR. As you can tell, lesions rehydrate during angioplasty and after angioplasty, it comes all back to the sponge. However, nitinol stents itself cannot be remodeled once they're actually fixed into position. So the rationale behind ISR therapy, suboptimal results with balloon angioplasty are very common. As mentioned before, we have plenty of elastic recall with no positive modeling, and the suboptimal results would repeat bare metal stenting within ISR. You worry about embolization, no barrier for intimal growth and more seal pseudoaneurysms, and the luminal compromised by at least stent strut thickness. Therefore, the luminal size actually gets smaller. Mechanical stabilization of fractured stents, either with covered stents or nitinol stents, is probably crucial because that's what initially caused the failure itself. So at the end of the day, the 3 available FDA process or approved therapies for ISR, which includes the laser, the Viabond itself, and DCB. So Fem-pop ISR treatment, the Tosaka criteria classification in class 1, the short focal lesions. Class 2, the diffuse lesions greater than 50 millimeters, and then the class 3, which are total occlusions. As you can see, class 3 is over 85%, while the other two are about 50 to 53 respectively. So the Excite laser study performed by Dr. Walker and Dr. Dipple themselves is the first large prospective study to examine the effectiveness of laser atherectomy and the treatment of Fem-pop instant restenosis. It was designed to enroll a maximum of about over 300 patients, and then it was highly statistically significant superiority in both safety and efficacy in both the patients treated. The treatment arm was a laser atherectomy combined with the percutaneous balloon, and the control was just balloon alone. So the freedom from major adverse events from target lesion revascularization through 6 months, the primary safety endpoint was freedom of major adverse issues at 30 days, include all-cause mortality, major amputation in the target limb, or TLR. Major inclusion criteria included instant restenosis, target lesions are greater than 40%, a vessel diameter between 5 and 7 millimeters in Rutherford class 1 through 4. Total of patients were enrolled in the treatment arm, as mentioned before, and 81 enrolled in the control arm. Both groups were similar in the baseline demographics and lesion characteristics, and the lesion average, like I said, about 190 millimeters, more than 30% of the patients presented with the total occlusion of a Tosaka 3 or above. So overall, the conclusions for the laser plus angioplasty is superior just to laser alone in the treatment of Fem-pop ISR. It's the first FDA-approved randomized control study demonstrating the benefits of laser atherectomy in lower extremities. And then laser extremity plus the actual angioplasty says the only atherectomy treatment FDA include for Fem-pop ISR. To add to this, the laser balloon and DCB compared to DCB alone, the randomized, the laser and DCB with 24 on one side and 24 in the DCB only. All diabetic ZLI total occlusions. Treated length was greater, 100% crossing success, and complications, as mentioned, with distal embolization 3. No perforations and no dissections. As you can tell, tread across the board, laser plus DCB was far better and better outcomes long-term wise, which is now part of the adjunct therapy, as mentioned before. And so finally, we'll go over a quick case. So a 66-year-old male with Rutherford 4 claudication. As you can tell, severe instant restenosis with complete occlusion of the distal stent with reconstitution at the level of the P3 segment of the popliteal with an excellent runoff, which is very good to see. So next image. So knuckle cross using a stiff angle glide, and looks like a quick cross. Crossed through the lesion. A puff was taken. Through the actual quick cross itself, just to make sure that we're actually in the lumen itself. And there we go. Next, the wire was placed distally. You can consider a filter wire. That actually would help in this situation of poor runoff, maybe one vessel, two vessel runoff. You can also leave the distal cap of the stent itself, just in case you don't have a filter, and you can use that as a filter at the end. Consideration for severe thrombus. You can potentially run an angiojet or a new CAT device to remove majority of the thrombus before you proceed on with the laser to remove the maximum amount of thrombus. So going on, here's the laser itself. Slow, 1 millimeter per second transition time. And then moving on. This is after the laser itself. And as you can tell, a great passage traveling all the way down the laser. No thrombus propagation is noted. And the key to this is actually taking your time and going slow to let the laser really do its work. And so moving on, this is a balloon angioplasty and DCB, and then final outcome. Excuse me. Excellent results. So you can get this on the plane. And there we go. Overall, conclusion wise, a new paradigm in emerging treatment for Fem-pop ISR works extremely well if done correctly. PTA alone has failed against 3 different treatment strategies. The DCB is effective for lesions greater than 10 centimeters, even though lately DCB has somewhat been out of favor. This discussion that you need to take with the patients themselves. And then the laser atherectomy is effective for long lesions and the FDA approved for ISR. And then combination therapy still needs further investigation. Thank you very much. Here's my email. Please contact me if you have any questions. This is my Twitter handle. Thanks again to Dr. Walker and the great NCVH team. Thank you very much.